Good morning.
Good morning.
All right. This morning we have Dr. Kishore Vellody. Dr. Vellody, correct, completed his medical degree at the University of Illinois at Chicago College of Medicine and his pediatric residency at the Children's Hospital of Wisconsin in Milwaukee. He is currently an associate professor of pediatrics at the University of Pittsburgh School of Medicine. Since 2005, he has worked with the Diagnostic Referral Service at Children's Hospital of Pittsburgh of UPMC as director of the Evening Hospitalist Program. In March 2009, he assumed the role of medical director at the Down Syndrome Center of Western Pennsylvania. Since then, Dr. Vellody has spoken at a variety of local, regional, and national meetings on the care of children with Down syndrome. Dr. Vellody became a pediatrician in large part because of his relationship with his older brother, Das, who is smart, funny, caring, and also has Down syndrome. This morning we have left evaluations on the majority of the chairs here, so if you're sitting in a seat that didn't have one, please pick up one off of the empty seats, and if you would fill those out and leave them on your chairs at the end of the session. Thank you. Dr. Vellody.
Good morning. I tend to wander, so I hope that's okay. And if you are in a seat that doesn't actually have a good view of the slides, feel free to stand up. This is kind of an interesting setup for the room with this big old table here in the middle, but feel free, I won't be hurt. There will be time at the end for questions. One thing I've realized, having done this talk now for the last few years, is that a lot of you guys come from areas where there are not Down syndrome centers, and so it can become difficult when you have a specific medical type of issue you were wondering about to get those things answered locally. I'm not going to give you, of course, specific medical advice to your child, but you can hypothetically pose questions at the end, and I'm happy to answer them. Today's talk is going to be primarily discussing medical issues in childhood all the way through adolescence, but we do also talk about adult issues during this talk as well, although the vast majority of the real medical issues that we deal with are going to be in childhood, but some do persist into adulthood, so there will be overlap with some of the things you might be dealing with your adult family member with Down syndrome. We're going to talk about some of the typical developmental and educational issues that we see in children. There are healthcare guidelines that the American Academy of Pediatrics has put together to help us as doctors know what tests should be done when and kind of focus more on preventative care rather than waiting for somebody to have a medical issue and then treating it. This is more preventative. How can we find out if a child with Down syndrome has a medical issue before they really have problems with it? And that's our goal in medicine is to do that, particularly when we work with children with Down syndrome, because we know that a lot of what comes up is highly manageable if we find it early. And then I'm going to talk to you about what a comprehensive Down syndrome center does and why you might want to think about talking to folks in your area and how you can go about setting one up in your area. Even as parents or family members, it is possible. That's where our center came from, and I'll give you more information about that as well. Just a very brief history of where medicine has come from in terms of understanding Down syndrome. It was first described in France by a guy named Edouard Onesimus Seguin. He's this nice bearded guy here in the corner. Let me see. I didn't check to see if this thing works. Yeah. But he didn't write anything down necessarily, so it was never known by his name. And then this is John Langdon Down, who keeps his beard more on his sideburns, I suppose. And in 1866 in England, he actually wrote the first paper describing Down syndrome. I would never recommend it to families to read because we didn't know very much. He didn't know very much about the medical aspect of Down syndrome. And in fact, about 100 years went by before Dr. Lejeune, back in 1959, found out that there was a chromosomal basis to the diagnosis. So that's a little bit of the background, really somewhat recent in terms of our understanding of Down syndrome. Everything that we see in Down syndrome is related to the extra 21st chromosome. We all have 23 pairs of chromosomes if we don't have Down syndrome. And if you do have Down syndrome, then your 21st chromosome comes in triplicate. Now, it can happen in one of three ways. The majority of people with Down syndrome have trisomy 21. That's about 95% of people. The medical stuff down here is really not all that important, other than knowing that it is often a misconception that everybody who's born with Down syndrome inherited the extra chromosome from their mother, and that's not the case. There are paternal origin of the extra chromosome as well. And I find that sometimes mothers put too much pressure and stress on themselves when we first give the diagnosis and say, all my fault. That's something that we definitely want to stress, that we never know where the extra chromosome really comes from, and it really doesn't matter in terms of the medical issues in Down syndrome. So this is what, when they send chromosomes, this is what the genetic doctors are looking at. These are the 23 pairs of chromosomes in this boy, XY, we see here. And he has 3 chromosome number 21s, which is the trisomy 21 we were just talking about. Translocation type is important to know about, because if your child does have translocation type Down syndrome, it does lend itself to a higher incidence of future pregnancies with Down syndrome. Oftentimes, one of the parents might be a carrier that can be transmitted to future children. And so, in this situation, this boy has Down syndrome, and it looks as if he only has 2 chromosome 21s, but his third one is actually attached here to chromosome 14. This is what we call in the medical world Robertsonian translocation, which you may have heard before. And essentially that means that the chromosome 21, that is the third one, is attached to the chromosome 14. And why is this important for you to know? It's because this is the father of that child. And in his situation, it looks like he only has 1 chromosome 21, which is not possible to have, but actually his second one is attached to his chromosome 14. So this father does not have Down syndrome, but he has an increased chance of having future children with Down syndrome. And so it's sometimes important for families to know that, and that's why we do check the chromosomes in the babies. And if you don't know which type of Down syndrome that your family member has, it's an important thing to probably find out just for this purpose. And then the last type of Down syndrome is mosaic type Down syndrome. And this is something that we don't really fully understand or grasp even to this point, why it happens, when it happens. Mosaic type means that some of the cells in the body have, of the person with Down syndrome have an extra chromosome 21, and some of them don't. And so we have some interesting cases that we have seen where I'll have a child that comes in and developmentally and medically and everything is great, but the reason they're seeing me in Down syndrome clinic is because they developed a condition, let's say like leukemia, for example, and when they checked the bone marrow, all of the bone marrow cells had an extra chromosome 21, but the rest of their body did not. And we don't know what that means. We don't know whether medically that means that they should have their thyroid screened and all the stuff we're going to be talking about. But it is an interesting thing that perhaps there are other people in this room today who don't know that one of their cell lines might have an extra chromosome 21, but it just hasn't impacted us medically or developmentally to this point. So if you do have questions, I don't remember if I told you this before, if you do have questions, write them down, and at the end, I will definitely save us some time to do that. So go ahead and write your questions down if you have any. Okay, how are we making the diagnosis these days? I think this is important for you guys to know because there's a role that we all play now that we didn't play before. Before, let's say, 2 or 3 years ago, there was a blood screening that we would do, or that the obstetricians would do, and about 95% of the time, they could accurately detect Down syndrome in the baby before the baby is born. But now, within the last 2 or 3 years, they've come up with a new testing mechanism where they actually test mother's blood, and with almost 100%, if not 100% accuracy, can find out whether the baby inside has Down syndrome, and they can do this very early in the pregnancy, which lends itself to the question, why does that matter, and why does it impact you guys? What happens is now that there are more accurate prenatal diagnoses means that more diagnoses are being made early in pregnancy, which then means that more of the diagnoses are being delivered by obstetricians. And as a pediatrician, I feel like when that has now gone more to the obstetrics world, what we found in studies that have been done by obstetricians by self-reporting, they are not very good at delivering the diagnosis. I'm not saying pediatricians are very good either. I can tell you they're not many times based on the stories that parents will tell me. But obstetricians are even worse in the studies that they've done, and they're fully aware of the fact that they're not trained effectively to deliver the diagnosis. So what does that mean for you and for me is that a family's role suddenly becomes very important, because how we show our children or our family members with Down syndrome, how we talk about them, how we introduce a pregnant mother who may be having a time of decision to make, I think it's hard for obstetricians to know both sides. And while we never take more of a legal stance one way or the other on any type of issue, I do think it's important for families to receive balanced information. And it's very hard to receive balanced information in this day and age, and we're hoping to change that with our OB colleagues. But for now, it's very important for us all as family members to recognize our role and getting the word out about what Down syndrome really means. Okay, so now when we talk about making the diagnosis, it's about 80% of the time or 85% of the time that a family receives the diagnosis after the baby is born. And so some of the features that are listed here, your child with Down syndrome may have, your children without Down syndrome may have, you may have. I won't take my shoes and socks off to show you my wide space gap between my first and second toe, but I have one. Some of you may have a single palmar crease. All of those things taken alone, of course, do not make the diagnosis of Down syndrome, but this is what the doctors are looking for when they're becoming suspicious for Down syndrome. The one that is most common is this, hypotonia. And I'm sure if you had a child with Down syndrome, you remember how hypotonic your child was when they were first born, especially. And you can see here how, this baby really is not giving much resistance at all to this examiner. You're not really, trying to lift the head even a little bit. And so this is the significant hypotonia that we see in newborns. As time passes, they still have lower muscle tone, but the muscle strength can kind of overtake what the lower tone is talking about. Tone and strength are two different things. When you have low tone, that's more of your resting tone. So when you're sitting in your chair, the reason your head's not flopping over is not because of your strength. It's because your muscles just naturally can maintain your posture in the way that it's there. But if you were, let's say, to fall asleep, which I hope you don't do, your muscle tone would more take over, and you might start to flop your head forward. Now, babies and people, especially infants with Down syndrome, have that lower muscle tone. Like I said, as they get older, the strength tends to take over more than the tone issues. And some of the facial features which I put here just to show you now so that when we talk about the medical issues that come about, we can see why they happen. This little cutie has what we call mid-face hypoplasia, where so much of what's going on in his ears, nose, and throat all centers around this very area of his face, and things tend to be very crowded in that area, so it lends itself to a lot of the medical issues we're going to be talking about. This is just, I put up here, not because there's any visual consequence, but it's one of my favorite features of Down syndrome. These are the brush field spots that you can see, and when you look with a light, as a doctor, when you're looking in their eyes, it just brightens up the room. There's little diamonds inside the eyes, so that's no visual consequence, but I just like that's one of my favorite things that we see. This little guy, you can tell, has a lot of mouth hypotonia, so the tonin is keeping his jaw open. Hard to see a little bit with the light, but his tongue is protruding as well. And there are a lot of issues related to the tongue in people with Down syndrome. It's not necessarily that the tongue is too large, it's actually that the mouth is too small for a natural or a typical tongue size. This is thankfully not a baby for his mother, but you can see here the high arch to his palate. Now, the palate is, of course, at the top of your mouth, also further narrowing the middle of the face because the arch is going up and into the nasal cavity. So it can lend itself to a lot of feeding problems, but also speech issues and sleep apnea type issues as well. And this little guy has what we call a ear skin tag there, and that can sometimes make us want to look more towards kidney issues as well, because the ears and the kidneys are developed at the same time. when you're inside of your mom. So there's some of the features that we see in kids with Down syndrome. And these have no medical consequence, but are very commonly associated with Down syndrome. This is a single palmar crease. Let no one call it anything else, because that is offensive. It's a single palmar crease. So we want to try to move away, both into the medical field, but also as we engage in our discussions about what we call things. So single palmar crease. This is a wide space gap between the first and second toe. And then this is fifth finger, what we call clinodactyly, which is that curvature usually of the fifth digit that folks with Down syndrome can have as well. But when you put it all together, you get a very cute little baby. Now, this baby's mother, of course, gave me permission to use the picture, and she is a newborn photographer, which I did not know existed when my four were newborns, and I'm glad my wife didn't know existed as well. But, so what's interesting is her baby was very hypotonic, and I said, how in the world did you do this? How did she brace her head like that? I guess there are hands that you can Photoshop out that are holding onto the head. So I think that's a really cool picture. I mean, it shows, of course, how much flexibility she has with her legs, but, her head's able to look like it's held on her hands. Anyway, so what can we expect? This is a very common question that I hear from new families in terms of developmentally, what can we expect throughout childhood and adolescence for children with Down syndrome? There very commonly are some delays that we see. Gross motor, which is kind of your walking, running, jumping, climbing, those issues do happen a little bit more commonly in people with Down syndrome. Fine motor, using your hands to manipulate small objects, that pincer grasp takes a little bit longer sometimes. Handwriting can be a little more difficult as they get older, using scissors, button zippers, that kind of stuff. So those are more of your fine motor things. And then speech-wise, it's an interesting phenomenon, and you guys who have children with Down syndrome or know someone with Down syndrome can probably recognize that receptively, the children seem to understand things at an age-appropriate level. When you tell them, hey, go to the car and get this thing or whatever, they'll do it. But if you ask them to then relay, what did you just do, the verbal output can be a little bit more difficult in those first few years of life. And so it's important for families to know that, while there might be a verbal speech delay, don't think that your child doesn't understand when you tell them no for, hitting their sister or brother, as it may be. And it's an expressive language delay more than a receptive thing. But I think one thing that doctors and professionals will forget oftentimes, and I've got a whole slide dedicated to it, are the positive aspects of the extra chromosome. Kids with Down syndrome tend to excel, and adults tend to excel in areas of development, particularly personal and social skills. When my brother, as you heard, has Down syndrome, and when he and I are together in the same room, he's the one that's running the show. I'm kind of back in my quiet mode, and he's the guy that everybody wants to talk to, because that's just how he naturally has this personal social skills that I don't have, or as naturally, it doesn't come as naturally as it does for him. And so I think, again, when we think about Down syndrome and we get those books, please don't buy the black and white books. Those are very wrong. But, as time passes, we've learned so much more about the benefits of the extra chromosome. And I get excited. I don't want to miss the time to show you some of those features here in a slide at the end of the talk. So this is just going to show you in a table format. I'm not going to go through each of these, but give you an idea of the milestone that we're looking at in the left column, a child without Down syndrome when they usually, on average, attain those skills, and a child with Down syndrome on average when they get those skills. Again, these are averages. So we have some children who do far, far better in terms of attaining these skills earlier, and we have some kids that just takes them a little bit longer. But one thing that's important, especially if you have a young child with Down syndrome, is to recognize that I don't have a clinic. We see over almost 500 kids a year in the clinic. I don't have a clinic where the kids come in on wheelchairs and aren't walking and talking. My clinic is very much one where I get hugs and enjoy my time, and the kids are, as they get older, certainly achieve those milestones, but it just takes them a little bit longer, and it requires patience from us as the medical provider, and it requires patience from you, especially as the parents, to not try to force this pathway down what is the quote-unquote normal. We want them to develop their skills in the order they're supposed to develop them. Why? Because if you give a child with Down syndrome a walker, let's say, because grandma says it's time for them to walk because they're one, or your baby book says that, or something like that, they'll certainly walk. But they'll walk with a lot of issues with their tone because they just haven't developed those intermediate skills. And so we have kids who kind of do this, they walk and they have their knees locked and their hands out to the side because they haven't developed all that tone that they need to get there. So patience is key, and it's hard, as a parent to have that patience, but patience is key when we're looking at developmental milestones. And boy, when we're talking about patience, this slide, I spend so much of my time talking about a lot of the things on this slide in terms of, here's some of the fine motor stuff, but especially the bowel bladder control. When we look on the average American child where they get to these things, a child with Down syndrome, it's going to take them a little bit longer to get there. So your 4-year-old may not be perfectly toilet trained yet, and that can be difficult, and it can be hard for the school system, and I appreciate all of those things, but it's really important, again, for there not to be battles set up with toilet training, but for there to be a chance for the child to succeed and to figure out what is their motivation is oftentimes the most important thing. And we'll talk about where you can get more information about toilet training, especially, because I know that's an area of a lot of stress for many families. So where can you get your supports early on developmentally? You get that through early intervention therapies. Now, I am working in Pennsylvania. We have very good early intervention services, but I know that not every state is the same. In fact, our families that come from Ohio or West Virginia, they just don't have the same supports. So if you do have good early intervention supports in your state, take advantage of them. Not because, again, it's going to make your child get to those milestones sooner, but because it will give them the right intermediate steps to do. They'll show you the right intermediate steps to do in order for your children to get to those milestones appropriately in a way that you're not spending years correcting what they've developed. And so that's from birth to 3. It's a federal funded program, the Early Intervention Services. And then local school districts take over at 3, and of course there's wide variability in how good the school district is going to be depending on where you live. But local school districts will take over after 3 years of age. So those first few years of life, studies have shown that those early intervention services are perhaps the most important thing you can do developmentally with your child. So let's go through some of the medical issues and some of the guidelines that have been set in place. We talked about this already when we were looking at those chromosomes. Every child with Down syndrome should have a chromosome study sent for a variety of reasons. One is, of course, like we were talking about, to detect what type of Down syndrome they have. And then 2, many services are provided for children, but you'll be asked as a parent to provide proof that your child has Down syndrome, and oftentimes having a chromosome report in your hand is the proof that they need. And so always keep a file and include in there the chromosome report. If you don't have that, you should talk to your doctor who may have it and give that to you. And it can be done through amniocentesis or after they're born, but at least it should have the type of Down syndrome indicated. The most common thing that we think about in that first day of life after the child is diagnosed with Down syndrome is cardiac issues or heart issues. These are not intended for you to memorize, but I wanted to show you that the most common one is that it's called atrioventricular septal defect. Say that 10 times fast. So no, we don't. We call it AVSD. But an AVSD is extremely common. If the child with Down syndrome is born with a heart condition, very often that's the one that it's going to be. And this is kind of a picture form of what an AVSD looks like. Okay, this is your heart. It is not the Valentine's Day heart. That's actually a whole nother organ that we're not going to talk about that it actually is. But anyway, so this heart you can see here has the blue blood and the red blood. The red blood has oxygen. The blue blood it has lower oxygen level. It's come back from the body. And why do I go through that? It's because for those of us without heart issues, we have a septum here that divides the red blood from the blue blood, so there's not mixing there. So the oxygenated blood goes where it's supposed to go, and the old blood that's getting reoxygenated goes back to the side it's supposed to go on. But if you have an AVSD, one of the things you're missing is this whole entire septum. So there's mixing across the two sides of the heart. We also have valves. These are valves here that keep your upper chamber and lower chambers of your heart separate. But in somebody with an AVSD, those are also usually atretic or not fully formed. And so what happens is there's mixing in all four chambers of the heart, which of course is not compatible with long-term life, and so it needs to be corrected. And why do I say that? I say that because it's not that long ago that children with Down syndrome were not even offered heart repairs. It was in the 70s, really 80s, when doctors first realized that children with Down syndrome should be afforded the same medical care as everybody else. And so, it was actually parents who had children who had a heart condition or had an intestinal condition that needed to be surgically repaired who said, no, this is wrong. And eventually the Supreme Court agreed. And so I think that's an important thing to remember, that advocacy from a family perspective is very, very important for all of us to do. When they do the surgical repair on the heart, it's usually when the kids are about 6 months old, because technically it's a lot easier to do when the children are larger, their hearts are larger, and so the hands can go in there and do the surgery that they need to do. And there have been at least 2 studies, if not more, that have come out in the last 2 years that have shown that children with Down syndrome for certain heart conditions actually do better than children without Down syndrome in terms of post-operative recovery. So the whole thinking was wrong before in medicine, that children with Down syndrome would not do well with surgery, that's why we wouldn't repair their hearts. It's actually not the case. In the right hands, the surgeries go very, very well. And it's important for your doctors to know that the children may not have a heart murmur on exam and still have a very large heart defect. So this is why in the healthcare guidelines, every child, every infant with Down syndrome should have an echocardiogram. The goal is that it would be done within the first 2 months of life and that it would be read by someone familiar with reading infant echocardiograms. And so this is one of those times where the drive to your closest major medical center might be worth it. I know at least at our hospital, the cardiologists actually have contracted out with a lot of the regional hospitals, like out in the middle of the state, where out in the middle of the state will do the echo, and then electronically, through the magic of the internet, will send the images to the cardiologist, who actually doesn't have to then go anywhere. They can read the echo right there in their office, and so then the children are getting the care that they need to get. So there may be something like that set up if you're not close to a major medical center. But if not, definitely a good idea to have the echo read at a pediatric cardiologist's office. And then after that initial echocardiogram, if your child is one of those that does not have a heart condition, that's great, actually, because they don't typically develop something in those early childhood years of life. But as they get older, into the teen years and adult years, if they have a new murmur, or if there's complaints of chest pains or shortness of breath when they're getting active, that's a reason to repeat the echocardiogram at that point. So even if your child or family member with Down syndrome is in their 40s or something like that, if they have a new heart murmur, it's not something to ignore. They should get checked again because of that lower tone, some of those valves can get leaky over time and might even need to have surgical repair later in life. So they should definitely be followed by their primary care doctor closely for new murmurs. And then as far as gastrointestinal, this is probably the second most common thing that we think about in the early newborn period, is the obstructions along the intestinal tract. So a baby with Down syndrome who's having feeding difficulties or vomiting or not passing those initial meconium, those black stools, should be evaluated for an obstruction. These are all just examples of different types of obstruction. But pretty much from mouth to exit, there can be obstructions, and it should not be ignored. So something for the neonatologists, newborn doctors, or even the pediatrician who might be seeing the child at the one-week visit needs to be aware of. But stuff can even develop over time in children and adults with Down syndrome. Reflux is extremely common in people with Down syndrome, gastrointestinal reflux, and so something for doctors to keep in mind. Celiac disease, about 10 to 15%, depending on the study you read, will have celiac disease diagnosed. And the issue with that is really what's the role of testing in asymptomatic. So somebody has no symptoms of celiac. Celiac is that gluten and wheat sensitivity. So some of the more common symptoms that you'll see is whenever they eat any type of gluten-containing product, they'll develop bloating or gas or diarrhea or vomiting, or maybe as a child they won't grow very well. And so those are symptomatic children, and those we would test. We would test. But then we do know that there are a lot of people, both children and adults with Down syndrome, who probably have celiac, but it's not causing them any symptoms. And so if one of us in the room, which is about 1 in 120, has celiac disease, asymptomatic celiac disease can lead to things like lymphoma of the intestine and all that kind of stuff. But in people with Down syndrome, they don't seem to get that complication. So the new guidelines stated then, if you don't have symptoms, there's likely no reason to test for celiac in an asymptomatic child. Constipation, I also put also known as diarrhea, because this child came in and saw me because of the concern for diarrhea. But then we did an x-ray, and in an x-ray, all of this kind of grainy look around here, this is all stool. So this child was, as we say in medicine, FOS. People use different words for the S, but I'm a good boy, so I say stool. So this is a child who's full of stool, and what happens is all of the liquidy stuff kind of leaks out and around, and it looks like diarrhea, but really what it is constipation. And I can probably tell you that almost always when the complaint is diarrhea, if it's not something like celiac, it's usually this. It's constipation, and that needs to be treated, obviously very different than diarrhea would be treated. And then feeding problems we talked about when we were looking at the high arch of the palate and those kind of things, and the hypotonia in the mouth can also lead to some feeding difficulties. Some of our older friends, my brother included, when he eats, especially if it's McDonald's, good grief, it's gone in like 10 seconds because he chews and then swallows and chews and then swallows. So oftentimes, even in the adult, a lot of those chewing behaviors that they develop, we need to remember to remind them, hey, take some bites, because next thing you know, you'll gag and out it'll come. And so the swallowing issues do tend to be something that we want to keep an eye on as they get older, also because the risk of aspirating that into the lungs is still there. So we talked about if they have vomiting or constipation or something in the newborn period, we definitely want to worry about things that they're born with, obstructions along the GI tract. And we talked about the screening for celiac disease only if they are symptomatic. Respiratory and ear, nose, and throat problems are incredibly common in people with Down syndrome, even as they move into adulthood, because a lot of these are missed in the pediatric range. So this one is called, we have blood pressure, two types, one that goes to our body, and then there's blood pressure in your lungs. And so people with Down syndrome often have higher pressures in their lungs, which puts more of a strain on their heart. So anything that increases lung injury, we want to avoid in people with Down syndrome because they have a higher tendency to develop increased pressures, blood pressures in their lungs. So things like sleep apnea or recurrent aspiration of the foods into their lungs can cause those types of problems to occur more often. They get a lot, people with Down syndrome get a lot of colds, and they get a lot of issues with croup, which, is that stridor kind of sound that the kids can make, especially in the fall, winter, spring months. And so all of that is, again, related to the narrowing of the airway, like we saw in that one baby, the narrowing of the airway, of the upper airway. And then they get a lot of recurrent ear infections, the tube that drains your ears. So the inside of your ear actually drains out through your nasal passages. So you can imagine if you're all plugged up in here, it can make it difficult for your ears to drain, which is why the kids get a lot of ear infections. We also know, based on some studies that ENT doctors have done, that the tube itself that drains the ear also doesn't drain quite as effectively because it takes a different course in people with Down syndrome very often. So they can keep a lot of fluid behind their ears, which can then lend itself to hearing loss. So, hearing loss is incredibly common in the lifespan of somebody with Down syndrome. Even starting in the newborn period, but even as they get older, they can develop hearing loss over time. And so it's important for people with Down syndrome to have their hearing evaluated, and we'll talk about that on the next slide when we do that. Recurrent sinus infections, again, because of the drainage of the nasal cavity being a little bit more difficult because of the narrowing of that airway. And then obstructive sleep apnea is a very hot topic and one we talk about every year at our annual medical conventions of all of the directors of the Down syndrome centers in the country, because it's suspected that, if not all, very close to all people with Down syndrome have some element of sleep apnea, even if there's no signs of sleep apnea. So, you think of sleep apnea as being loud snoring, and grandpa makes a lot of noise when he sleeps and all that kind of stuff. But in people with Down syndrome, parent report actually is not indicative of whether or not they actually have sleep apnea. So it is something that we know exists and is much more common than we ever thought before. So when we think about the healthcare guidelines, from a respiratory perspective, when they're leaving the nursery, if they have a heart problem, we need to make sure that their oxygen saturation levels are appropriate before they get into a car seat. Because car seats are asking for trouble many times, especially in a baby with Down syndrome who maybe has a little bit of lower tone. You put them in the car seat, they flop forward, and all of that obstruction gets even worse. If they have noisy breathing, in our institution we send them to ear, nose, and throat. Other folks may send them to pulmonology. It's really up to what your current area referral patterns are like. But ear, nose, and throat can take a look and see how bad those narrowing issues are. And then there's one immunization, the RSV immunization called Synagis. If the baby has issues with cardiac issues, they will, or chronic respiratory problems, they will qualify for that Synagis immunization. And that's something your primary care doctor can talk about as well. So what do? We do hearing screens very frequently. So across the country, every baby gets a hearing screen when they're first born, and including babies with Down syndrome, of course. And if the hearing screen has failed, they need to have that repeated within 3 months, because hearing loss, if it goes for too long, is obviously going to impact speech development. And so very important for the hearing to be reevaluated if they did not pass that newborn screening. And then even if they did pass that newborn screening, they should have formal hearing screenings done every 6 months, preferably with an audiologist in those sound enclosed booths that they have. The hearing screens that the schools do or that the primary care doctor's office does is not enough. So they really should have fairly frequent hearing screens, especially in those first 3 or 4 years of life when speech acquisition is very crucial. I've diagnosed at least 2 or 3 kids who have had significant hearing loss and speech delay, and were told that the speech delay was because of Down syndrome, when really it was because they had persistent middle ear fluid, or they had a problem with their nerve that sends hearing signals to the brain. So very important for them to get hearing screenings done by an audiologist. And then, of course, if they have concerns for hearing or recurrent ear infections, otitis media is ear infection, if they have a lot of those, then ear, nose, and throat should get involved. We have found in studies that ear tubes, when done early on in the course of a child with Down syndrome who has hearing loss because of middle ear fluid, can definitely impact speech development. That's actually a little bit different than kids who don't have Down syndrome, where we're trying to avoid tubes, because we really haven't seen in studies that that's as effective. In people with Down syndrome and children with Down syndrome, getting those tubes in early has been shown to be effective in their long-term speech. And then I put this in bold and in italics. The sleep study is a very controversial part of the guideline. I think it's an important part of the guideline. It's controversial because not everybody has access to a pediatric sleep center where they can do sleep studies. And so, but the guideline says everybody with Down syndrome should have a sleep study at least once in their life, preferably by the age of 4. And if you do a sleep study, let's say at your local regional hospital that's more used to adults, there's 2 problems with that. One is the techs don't know how to, really work with kids, especially kids who might have a lot of facial sensitivities with, stickers and probes on their face and on their chest. So they may not be as good as a pediatric place would be. And the person reading the study is not going to be very used to reading pediatric sleep studies, which have a very different normal and abnormal range. So this is another reason to take that drive, is the sleep study part of the guideline, to take that drive to a center that's more used to working with children, or if your family member is an adult with Down syndrome, because I think that makes the whole experience a lot easier for them. And then I put this last one on there to remind us that still upper respiratory infections, just like in every other child, is more likely to be viral. Okay, so just because your child has Down syndrome doesn't mean they should be overloaded with antibiotics. I know I'm a doctor and I'm saying don't give antibiotics. But that's the way our mentality should be, because it might take them a little bit longer to clear their cold, but it's not necessarily going to clear faster. A viral infection definitely is not going to clear faster with antibiotic, and then you're subjecting your child to whatever the risks of antibiotics are and all that stuff. So patience, again, is important when it comes to recurrent respiratory drainage and all that stuff. We have some families that they're well-intentioned pediatrician or family practitioner at the moment of the first day of runny nose puts them on antibiotics. And we try to avoid that because I think that's going to lend itself to trouble down the road for that child, probably. Eye issues are very common in people with Down syndrome. I'm not going to go through each and every one of these, but the issues with the eyes are common. And so that for that reason, we recommend that they be seen by an ophthalmologist fairly frequently. If there's a concern right off the bat with the child with Down syndrome when they're a baby, we send them to an ophthalmologist right away. But if there's no concerns, this is the guidelines that we follow. So within the first 6 months of life, and then every year for the first 5 years, every 2 years for ages 5 through 13, and then every 3 years from 13 to 21. But if your child's ophthalmologist says, oh no, we need to see you guys every 6 months, follow that. This is just a general guideline. It shouldn't go longer than those time frames because eye issues can develop over time. And again, may not be easily picked up just by a primary care doctor. Endocrine means your hormone system. It can be affected in Down syndrome primarily through what's the hypothyroidism. So your thyroid is a gland that lives in your neck, and that gland very often in Down syndrome can become underactive. And the problem is the symptoms of hypothyroidism are very similar to the symptoms that we see in Down syndrome in general. So things like slower height gain, increased weight gain, dry skin, thinner hair, some developmental issues. All of those things happen in hypothyroidism and in Down syndrome. And in fact, to the point that at one point in medicine, before we knew about the chromosomal basis of Down syndrome, hypothyroidism was thought to be the cause of Down syndrome, which of course we know it's not now. But they're very similar. They can be born. Babies can be born with hypothyroidism. That's the congenital hypothyroidism, and that's screened for on the newborn screen across the country. So they'll pick up on that. But then you can also acquire it over time. And so, when the child comes in, let's say 5 or 6 years old, and they never really had problems with constipation before, but now they do. It might be hypothyroidism, but you don't know because it also happens in Down syndrome. And so, very important to keep track of that. Hyperthyroidism is a overactive thyroid, and less common than hypothyroidism, but does happen in Down syndrome as well. And then diabetes, the type 1, the insulin-dependent type, is the one we see most commonly in people with Down syndrome. For whatever reason, even with some of the obesity issues we deal with in pediatrics and in adults with Down syndrome, the type 2 diabetes or the obesity-related diabetes doesn't seem to happen quite as frequently. But the type 1 or the insulin-dependent type of diabetes does happen a little more commonly. And then growth hormone deficiency, I list there because it's in the textbooks. I'll be honest, we don't see it very often at all. And so it's not something that I think about frequently. So the thyroid screening is very important. We talked about the one at birth, and then they should get one at 6 months of age and then a year of age. And then after that, it's checked every year for the rest of their life. And it's, again, one of those things where we are really happy. There are very easy early signs to pick up on when you send the labs off. The TSH is the one that your brain tells your thyroid gland to start making thyroid hormone. That one tends to get abnormal first, even before they develop signs of hypothyroidism. So if we can catch it early, we can start treating early, and then they don't run into any of the issues of hypothyroidism. So this is a really important thing to keep up on, is getting the thyroid screened frequently. And then if they, of course, have symptoms of diabetes, which would be going pee more often than usual, or being hungrier or thirstier than usual, or vomiting abnormally, that would be a reason, of course, to screen for diabetes. And again, the growth hormone thing, that's something that we just don't see very often. So this is one that families are often quite worried about, even at the newborn visit that I have with them, which is this leukemia. Okay, so this is what leukemia looks like under the microscope. All of those purple cells are the abnormal leukemic cells. And leukemia happens in about 1% of people with Down syndrome. The vast majority of people, if they're going to develop leukemia, are going to develop it in the first 5 years of life. We don't really see very much leukemia and Down syndrome beyond that. Beyond 20, we just don't see it very often. it's still 1%, which means that, in the general population, especially in children, 1 in 1,000 children will develop leukemia. In Down syndrome, it's 1 in 100. So it's definitely more common, but it's certainly not the vast majority. I mean, we've had families who have done some reading on the internet, and they'll say, well, when is the leukemia, going to come? It's not like that. It's not very common at all. But it is something that we think about. Some babies, about 10% of babies, can actually be born with a form of leukemia in Down syndrome. That's, again, a big mouthful, transient myeloproliferative disorder, but we call it TMPD for short. That's a nice way to do that. And this is one where the baby is born with what all the world looks like leukemia. It looks just like this slide picture, but then it goes away in about 3 months on its own with no treatment. And nobody really understands why that happens. But what we do know is that the children who have had that TMPD disorder when they were first born will have a much higher incidence of having leukemia, AML, that type of leukemia in those first few years of life. So we send them all to hematology to be followed very closely, again, to catch something before it gets really set in their bodies. So that's the leukemia part of it. And then iron deficiency anemia is very common in people with Down syndrome. I don't think it's related directly to the extra 21st chromosome. I think a lot of it is related to kind of the pickier eating and sensory issues that a lot of the children will have. And so, getting my kids who don't have Down syndrome to eat broccoli is hard, but we can get it. But getting my brother to eat broccoli, and he's 40 years old, he won't eat it. It's just, so iron deficiency is quite common because of those self-imposed many times dietary restrictions, so we do want to watch for that. So at birth, all of them get a blood count. A CBC is called a complete blood count. They all get a blood count at birth, and of course, if there's abnormalities there, like that TMPD we were talking about, they all get referred to hematology. And then, beyond that, every year, forever, along with their thyroid screening, they should have a screening for anemia done every year to look for signs of iron deficiency anemia, even into adulthood, because like we were talking about, the dietary issues don't necessarily get much better many times as the children become adults. And then, two, the celiac disease we were talking about before, one of the symptoms it can have as a presenting feature is iron deficiency, because celiac prevents iron absorption in your small intestine. And so it can be a sign that we should be looking for celiac disease in somebody, too, if they have persistent iron deficiency. Immune-related issues are common. As we already talked about how the kids have a lot of recurrent colds and infections. Part of that is because of the anatomic differences we were talking about. Part of that also is because of the immune differences that people with Down syndrome have. We don't exactly know why they have these immune issues. We know that their antibody levels tend to be a little bit lower, so antibodies are what fight off infections in our bodies. And we know that they tend to be a little bit on the lower side in people with Down syndrome, so that probably increases their risk of infection. We also know that for whatever reason they have an increased risk of what we call autoimmune conditions. Autoimmune conditions are where your body's immune system goes a little haywire and starts to fight itself. So things like type 1 diabetes we were talking about, that's an autoimmune condition. Vitiligo, which is a skin pigment issue. Alopecia, which is a hair loss issue. Celiac, which is we just talked about. All of these are autoimmune conditions. So in some regards, their immune system underfunctions when we're talking about fighting infections. And then in some other regards, it's overactive in terms of these autoimmune conditions we're talking about. So it's an interesting phenomenon, again, not fully understood at this point. This is an issue that we do see quite frequently in pediatrics in general, but very much more common also in people with Down syndrome because they spend a little bit more time on their backs, maybe because they're not rolling over quite as frequently when they're first born or as soon as other children, or maybe because they prefer spending their time on their back. And what happens is that flattens the side of your head. You see how this child has one side of his head is flattened there. That's called plagiocephaly. And we see that very, very commonly in the kids that we see in clinic, and it's something that we need to keep track of. And then what you do is you put a helmet on them, and it helps to straighten out this problem. I'm from Chicago originally, so hence why I love showing that picture with the Bears helmet. Other issues, orthopedic-related issues, are all pretty much related to the lower tone that the kids have. One that we see quite commonly is this ankle hyperpronation. If your child is at the walking age, you'll probably have noticed this perhaps. People with Down syndrome tend to have flat feet because the arch also depends on our tone. And so when they stand, that arch flattens, and then they tend to walk on the insides of their feet. And the reason that's important to recognize is if you try to walk on the insides of your feet for the rest of today, you'll notice your knees will start to hurt and your hips will start to hurt. And, we know, of course, that there's a lot of issues with endurance with a lot of people with Down syndrome. And I have found that if we are able to stabilize this ankle joint with something like these types of orthotics that are not cumbersome, but they just kind of give you the inability to kind of do this sideways turn, allows the up and down just fine, which is what you want for walking, but doesn't let them kind of walk on the insides of their feet, it actually helps with a lot of these endurance-related issues. And so something to think about if your kids are dealing with that, that's an important thing. I think one company even is here, Sure Steps. We use them a lot in our clinic because they're very easy to find and very well tolerated by the kids as well. And then patellar dislocation, this is the kneecap bone that we have. That bone can sometimes slip off in adolescents and adults with Down syndrome especially. And if it's not causing them any pain or symptoms, we just let it be. But if it is, then we refer them on to our orthopedic colleagues to do what orthopods do, a lot of drills and screws and whatnot. But they can hold it in place if need be. And then scoliosis is also under-recognized, again, because of the lower tone that the people with Down syndrome can have as they get into their bigger growth spurts, after the age of 10, you can start to see a little bit of a curvature of the spine. Very manageable. It's got to be something, though, that the doctors are looking for and catching. This one is one that a lot of families, again, worry about, too, and rightfully so. It's called atlantoaxial instability. So in our skull, our skull sits on top of our spine, and so the top bone of our spine is this one called the atlas, or C1, and the axis is C2. So what happens is, this is where they are in action. So you see here, this little finger projection that comes up off of the C2, that's what holds our C1 in place, and then your skull sits on top of all of that. And so there's a ligament that holds these two things together, your first and second vertebra together. That ligament can be a little bit lax in people with Down syndrome, and so you can get some sliding of the bones on top of each other. And the reason why this is important, and the patella one is not, is because this one's important because the spinal cord sits, or this black structure here is the spinal cord. The spinal cord sits right in between those areas, and so if there's slippage of those bones, you can, of course, injure the spinal cord, which would be a terrible thing, and I've seen it happen in at least 2 or 3 patients where it was preventable but not prevented. So, and it's devastating to the child and to the family, and so it's important for us to be aware of atlantoaxial instability. So it's very important for us to do a neurologic exam, a doctor is to do a complete neurologic exam, including checking their lower extremity strength and reflexes at every visit. If there's any change from a prior visit, that's a child that I'm going to be a little bit more concerned about, that atlantoaxial instability. And then we counsel all the families about trying to avoid excessive neck movements, especially during surgeries. If your child is going to have a surgery, particularly an ear, nose, or throat surgery where they're going to crank the neck back, when a child is under anesthesia, they have no protective mechanisms. They're asleep. So if you're cranking the neck back, it's very important to, if the anesthesia people or the ENT people are not familiar with Down syndrome, it's really important for them to know to avoid excessive neck movements. And then things like football and soccer and gymnastics, we can think about those things as putting children at a higher risk of spinal cord injury. But I don't tell families not to do those things, because I think that every part of life has some sort of risk, and as a family then we have to decide whether it's something that we're worth taking. Driving in the car today, if you drove to Indianapolis or flew on the airplane, had a risk. You could have gotten into a car accident, they could have had a neck injury, but you took that risk because it was worth it to come here and be amongst our family here. So it's important, though, if the child says something like, I love football and I love swimming. Which one should I pick? Well, pick the swimming. That's the level of I would take it at. But one thing we definitely want to avoid, the American Academy of Pediatrics wants us to avoid it in all kids really, but especially in children with Down syndrome, is trampoline use, because that's going to give them a higher incidence of uncontrolled falls and traumatic neck injury. So, if it's part of the therapy and the therapist is right there, that's okay. But I'm talking about, especially when there's multiple people on the trampoline, there have been studies that, not including just children with Down syndrome, but in general, injuries go way, way up when you have the games that the kids play where, one lays down on the ground and the other ones jump over them and all that kind of stuff. That's asking for trouble. So we try to avoid trampoline use. If the kids develop any symptoms that your doctor picks up or that you pick up on of neck problems, that's when we move towards doing the evaluation with neck x-rays or MRIs. Those symptoms would be things like tilting their head towards one side. They didn't used to, but I had a 4-year-old that came in to see me in a clinic one time and was walking around like this. And I said to the mother, I've never met your child before, but does she always walk like that? And then she says, yeah, the doctor thinks it's torticollis and we're doing PT. And, torticollis is something we see in babies. We don't really see it in 4-year-olds. And as it turns out, when we x-rayed her, she had terrible atlantoaxial instability. And what she was doing was protecting herself by walking like that. If you notice neck stiffness or pain with movement of the neck that was certainly not there before, that would be something to bring up to your doctor. If there's change in their muscle strength, be it in their arms or their legs, something to keep in mind. If they're toilet trained and all of a sudden now they lose bowel or bladder control that they once had, that would be something also to bring up. So those are some of the features that we would look for if we're worried about atlantoaxial instability. No longer is it part of the guideline to get an x-ray in everybody with Down syndrome. That was removed from the 2011 guidelines because what we discovered by doing studies is that the x-ray was missing some children and overcalling some children, so it wasn't a great screening test. And what was better than that would be to do an exam and then, based on what the symptoms were or what the parents were reporting, get the x-ray then. Okay, seizures are more common in people with Down syndrome. About 5 to 10% of patients will develop seizures at some point in their life. One in particular that we see more commonly, especially in the babies with Down syndrome, is infantile spasms. But I think that, here, let me show you this video. It's very short. This mother, of course, again, gave me permission, but sent me this video via her iPhone a few years ago. And she says, is there anything you would be worried about with my little guy here, who is developing great and doing well up to this point, but right now you see that movement. And it happens. This movie is about 3 minutes long, and it just continues like that the whole time, and in that rhythmic kind of movement. Those are infantile spasms that we were seeing in this child. And we were able to get him in to see a neurologist that very day, start him on treatment, and he's actually doing really well now. I just saw him. He's about 5 or 6 years old now, and doing really well, which is not what we would normally say for infantile spasms in a child without Down syndrome. Kids with Down syndrome actually do pretty well with infantile spasm treatment. Alzheimer's is something that has definitely changed in terms of what people think about. When I was in medical school in the late 90s, my textbook said that all people, 100% of people with Down syndrome have Alzheimer's by the age of 40. And I remember being devastated by that because, of course, my brother, I did not want him to have Alzheimer's. But that's what was thought back then. Now what we've realized is that while it is definitely more common in people with Down syndrome to develop Alzheimer's and to develop it at a little bit of an earlier age than in other people, it is not 100%. My colleagues who do adult clinics tell me that by the age of 40, maybe 10% will have symptoms and signs of Alzheimer's. By the age of 50, maybe 20 or 30%. By the age of 60, about 40%. And that's where it stays. So it's actually not the majority of people even with Down syndrome that develop Alzheimer's disease. And so important for us to realize that a lot of what you might find on the internet or even in medical textbooks might not be accurate. And then dental issues. I'm not a dentist, and I don't play one on TV, and I don't like going to the dentist. All right, anyone with me on that? But dental issues in Down syndrome are more common. So the teeth tend to have a delayed eruption pattern, while most of our typically developing children maybe have their first tooth at 6 months of age. We might be waiting 12, 18 months for that first tooth sometimes. And the eruption pattern is different. You know how most kids will develop their front teeth first, and then it'll expand to the back. And people with Down syndrome have had families come in and say, no teeth yet. And I look in, and there's 2 in the back. But they just didn't see those. So they come in different orders, different patterns. Missing teeth is a little bit more common in people with Down syndrome too. So it's very important for dental care to be provided as soon as the dentist will start seeing the children. We aim for about 2 years of age to try to get them into the dentist. And a dentist who's used to kids, I think, would be a great thing as well for them. And toothbrushing is difficult, especially if there's oral motor sensory stuff. But trying a variety of different types of toothbrushes or the vibrating toothbrushes, those kinds of things can be very, very helpful. Is it okay if I answer your question at the end?
Yeah.
Okay. So those are some of the things that we want to think about dental-wise as well. Immunizations, all childhood immunizations are recommended for people with Down syndrome, especially for people with Down syndrome because of their increased risk of infections, because of those immune issues we had talked about. But they tolerate the immunization series just like any other child and should remain on schedule. Only one extra immunization is recommended at the age of 2 for any child with Down syndrome and any cardiac or respiratory problems, and that's called Pneumovax. For adults with Down syndrome, I believe that's part of what they normally will immunize adults with in general, and so the doctor's offices are likely to carry that. In pediatrics, though, it's a little bit harder sometimes for the pediatricians to carry that stuff, so we definitely work with our community pediatricians about providing that Pneumovax vaccine for the children. That is one that prevents pneumonia, bacteria that also can prevent ear infections and sinus infections as well. We use standard growth charts for children with Down syndrome now. You'll find Down syndrome-specific growth charts. The problem is, what we found is that the data that was made to create those growth charts was old. It was from the 1950s and 60s, long before people with Down syndrome had the health care that they have now. We're close. We had an update yesterday during our meeting from the team that's recreating a new Down syndrome growth chart. Hopefully they'll be out and we'll be able to use those again. But for now, your pediatrician should just be plotting them on the typical growth chart and then following the trend of growth rather than the specific percentile. And then I also include here at the bottom for the teenagers and adults with Down syndrome, really important to do a lot of sexuality and abuse prevention discussions at their level. Because as those of us who know someone with Down syndrome who's a little bit older, they tend to still be very, accepting of other people. If somebody says, I'm a doctor, let's go over here and let me, look at the body. And it's scary, but there are horrible stories about people with Down syndrome being taken advantage of because of how trusting they can be. And so important for them to learn about how their body is theirs and who is allowed to see their body and those types of things to prevent those types of issues. And there are lots of books and materials for that as well to help guide that discussion. Dietary issues, we definitely want to make sure that children remain on healthy dietary choices because obesity is more common in people with Down syndrome. There's a limit to the height that people with Down syndrome will have, but there's, of course, no limit to weight growth like we all know. And so unhealthy food as rewards really should be avoided. I have this discussion with families, and then they say, okay, you did good at the doctor, let's go to McDonald's. I'm not saying you can't have some rewards, but sometimes it gets to an extreme. Every time you shake somebody's hand, you get a Snickers bar or something. That's too much. And it will lend itself to obesity, and of course losing weight is harder than preventing weight gain. And then avoiding unproven fad diets, I talk a lot about in our clinic as well. There's a lot of websites, a lot of people who are trying to be helpful, but then we'll try to sell you either on a diet or maybe a supplement or complementary medication that they say should be used. Just be cautious about those things. Talk to your doctors about those things. Read more scientific type literature about those things because a lot of them are certainly unproven, but can also potentially be harmful as well. So try to be careful with that. Behavioral stuff, my least favorite thing to talk about in clinic, because if somebody saw my kids and gave me behavioral advice, I would have a lot to take in. But I do want to make mention of a couple of things. ADHD does seem to be a little bit more common in children with Down syndrome. That's attention deficit hyperactivity disorders. There are problems with management of ADHD. One, many doctors feel uncomfortable managing ADHD, especially in a child with Down syndrome. And two, good luck trying to find psychologists, psychiatrists in your area as well that are, one, child-specific, and two, also comfortable with Down syndrome. So it's a challenge. It's one that a lot of us in the country are dealing with. And then autism. You've seen there's an autism track this year. I mean, it is definitely a lot more common than was previously recognized, co-occurring autism and Down syndrome. I would say, from what I've seen, about 5, maybe 10% will have some sort of autism spectrum that I follow in my clinic. And so it's something that is hard to pick out if you're not used to, one, seeing children with Down syndrome, or two, seeing children with autism. And definitely the combination of the two, very hard to find somebody who's used to that. Sensory integration or sensory processing problems, separate from the ones that we see in autism, are also more common in people with Down syndrome. And we can talk about that later if you guys are interested. And then I have made up this one called special child syndrome, otherwise known as chronic spanking or chronic timeout deficiency, depending on your persuasion. I've seen this time and again where Down syndrome or the extra chromosome gets blamed for a behavioral issue. And when it truly is, it's a modification of the way that the parents are handling that child than they probably did with their other kids. Remembering when the baby was first born and, the shock and, how sweet and kind and loving he is. And so you give up a lot of, on the discipline that perhaps the child could benefit from in the long term. And I'll have, 7 or 8-year-old kids who come into my office and throw their shoe at me and hit me, and the mom will say, or the dad will say, "Sweetie, now you go pick up your shoe." And really, if one of my kids threw a shoe at their doctor, I would say, "Oh my gosh, no, you don't do that," and I would do whatever discipline that we do in our home. And so, important for you guys to remember that as parents is that you want to set your child up for that when they are 18, 21, 25, 30, when they're going into the workforce. They're not going to keep a job if they throw their shoe at their boss. Do you know what I mean? And so, important for them to learn the right behaviors from an early age before they become adults. And then you're really dealing with problems as they get older with employability and things like that. Just a few more slides left. So, benefits of the extra chromosome 21, I think, are very important to know, because many of you may not have heard of any of these before. People with Down syndrome are very rarely diagnosed with solid organ tumors. So we might have, an epidemic of lung cancer or liver cancer or prostate cancer and all these types of cancers in adults as they get older. People with Down syndrome just don't seem to get that, and we don't know why. We know the only difference between them and us is the extra 21st chromosome. So there's something that is what we call oncoprotective or cancer protective on that 21st chromosome, and I think is an active area where people are interested in finding out what is it. Atherosclerotic disease, which is the cholesterol plaques in the arteries that we all worry about when we eat our Taco Bell and all that stuff, just doesn't happen in Down syndrome. We don't know why. But they can have cholesterol through the roof, but if you look at their coronary arteries or the arteries of their heart, they don't have those fatty plaques there. Nobody knows why. Hypertension or high blood pressure. I've never seen a hypertensive child with Down syndrome, but my colleagues who also do adult medicine have never seen, or very rarely, I think actually Dr. Bulova, who does it with me, has told me he's never seen a person with Down syndrome with hypertension, which, wouldn't that be great, for us as adults to figure out why, or what is it on there that keeps hypertension away. Dental caries or cavities. I'm not saying nobody with Down syndrome gets dental cavities. They do, but very much lower frequency than in the typical population. We see that they have better outcomes in certain types of leukemia. AML, which is a certain type of leukemia, they do better in that than other children or other adults do. Infantile spasms, we talked about how that was a seizure condition that responds better to treatment in people with Down syndrome. We all know of the typical non-medical type personality traits that many of our friends with Down syndrome have. Not everyone, but many of them tend to be more loving, more forgiving, more honest, tend to be people that, I want to be more like, you know what I mean? And so again, something on the 21st chromosome seems to keep, the desire to hurt other people. What'd you say? Organized tends to be something that the kids can have, adults can have. Not everyone. Sounds like not in your home. But it does tend to be a personality trait that we do see. And then visual memory skills, which is important for you guys as parents and family members to keep in mind. When you're trying to teach somebody with Down syndrome something, you can talk until the end of time. When I try to teach my brother how to use a new remote control, for example, we get a new TV or something like that, my mom will call me. I live in Pittsburgh. My mom will call me from Chicago and say, hey, can you do that on Skype and show him how to use this remote? But what works really well is using pictures or talking, with the thing in front of me. Say, this is the button for on, this is the button for off, this is the button for volume. And but I could sit there and say, go home, push the red button, then push the green button, and then push that. It doesn't work. But using visual cues is very helpful. So when the teachers are saying to you, I don't know how to teach your child, find out, are they doing it like we're doing now, which is verbal, or are they using a lot of more picture type or visual type skills? And I think that can be very helpful. Situational memory is one that causes much embarrassment to siblings across the country. Because my brother and many people with Down syndrome can remember situations and time frames like they were yesterday. Like he'll say, you remember when you were 5 and you cried at your birthday party, and remember how you wet your pants? And I'll say, that was years ago. I mean, why are you still talking about that? Yeah, remember it was at McDonald's, we had the birthday party there, and you were so upset because you wanted it at Burger King. No, I don't remember that. But he remembers that. So all of these types of skills actually go into, intellectually, they do really well with reading. If it's taught correctly, using more of, a visual style. Oftentimes the children do better with a visual type of learning of the word structure. Cat always looks like cat. It looks like that word. It's going to have that picture to it. It's better than learning that C says ka and A says a and T says ta. And a lot of the children, then as they get older, what studies have shown is they go back and they learn phonetics at a later age, but at the earlier age, they excel. A lot of the kids that I follow are actually above grade level in their reading because it was taught correctly to them. So, check out, I know that at the convention they always have folks, reading skills and teaching reading skills type of stuff. Maybe there's something there that could help you or your teachers there as well. So for the final couple of minutes, I'm just going to tell you what a Down Syndrome Center is and why it would be helpful if you guys are able to organize that. Because the care of a child or an adult, especially with Down syndrome, is really new. And within the last 25, 30 years, there's been some growth of Down syndrome centers like the one we have in Pittsburgh and, of course, across the country. But they're not easily accessible to a lot of people because there's just not many of them around. And so at our center, it was, or I'll tell you first why. Why is because, as you probably have found if you've had interactions, even with the greatest pediatricians or internal medicine doctors, the knowledge of Down syndrome is going to be not as good because they don't see as many people. Just by statistics alone, a very busy pediatrician might have 3 patients with Down syndrome that they see once a year. And so to become used to knowing what to expect, what do I expect at 2 months? What do I expect at 2 years? What do I worry about? What do I not worry about? Can be hard to do without volume. And so I'll give you just a couple of examples of kids that I've seen in clinic. We had a 3-year-old who had ADHD. The pediatrician tried to start them on low-dose stimulant meds, which is the first step that many people will take. The problem is what's considered low in the typical population is too high of a dose for somebody with Down syndrome. And so this child became very withdrawn and not himself. And then when we found the right dose, his ADHD got better, and so did the other behavioral changes that had developed. Or this 16-year-old who I saw who had behavioral changes, and they were diagnosing him with early onset dementia, meaning, you have Alzheimer's at 16, which is really very, very, very unlikely. And when we saw him, what it was that his 18-year-old sister had left for college. And he had no way of expressing his sadness over that. And when we were able to get him to start talking to his mom or his dad about that, wouldn't you know, his Alzheimer, quote unquote, went away. And so this is a child who would have been labeled with that diagnosis forever. And now we're able to very easily fix those issues. This I talked to you guys already before, but the 4-year-old with minimal speech and told they had slow development. That's what Down syndrome is. And of course, she had hearing loss, and that just didn't get picked up on. Or this, is an example of not overreacting. We had a 2-year-old who went to see neurology because every time she would get excited, she'd go like this and make a face. And they thought the parents were concerned this could be seizures. The pediatrician was concerned they were seizures. Went to neurology and got an EEG and an MRI and all that other stuff. And they came to see us, and I said, oh, man, you got to come to a birthday party sometime and see, like, when the cake comes out, even my brother and his 40-year-old friends are all excited, and the tongue clicking in the mouth and all that stuff. That's just part of the excitement reaction that many people with Down syndrome will have. So our center, I tell you kind of this model because I think it works really well for us, and I like the fact that it was created, our center was created by parents of children with Down syndrome in the Pittsburgh area back in 1989. They got together their resources. They had fundraisers and things like that, came to the hospital and said, hey, we want a doctor. And the hospital said, show me the money. They showed them the money, and they got a center. And that has continued every year since then. It's our 25th year now. Every year since then. And the reason that's important, I like that setup better than the hospital just providing the service, is because the hospitals, when I go in to see a patient, a 15-minute visit is what the insurance company wants, what the hospital wants, what everybody wants. But I'm spending an hour with the patients. Why? Because I'm not on the insurance company's time. And I'm not on the hospital's time. I'm on the parents' time. And so if I do my job right, they keep going back and doing fundraisers, and they keep coming back to the hospital. And it's a circle that continues where we're providing a service that the families want, and the families reward that by going back out and doing the financing of the center, which is a really nice setup. And we're a relatively small staff. There are actually only two of these. For the pediatric side of things, only me and Sheila are full-time in this. Everybody else is, Peter does the adult part of it, but from the pediatric portion, it's really a small group, but we make it work. And we do prenatal counseling. If the OBs call us, we go, and we talk to the families, and we tell them about Down syndrome. We don't tell them what decisions to make, we just tell them about Down syndrome, and then they make the decision that's right for them. And we see kids all the way through adulthood. We transition them over to Dr. Bulova at that time. And I love the fact that we have med students and residents and graduate students, and everybody comes through and rotates through our center so that we can impact maybe when the genetic counselor is going to talk to a mother, she's going to talk with a different way because she's met somebody with Down syndrome. She saw me in clinic working with the families, whatever. And I think that's a big part of what we do. This is our contact information. And I want to draw your attention also to the podcasts that we do. We have these podcasts that we do out of the center that are intended for parents and are just general information about Down syndrome, whether it be medical or otherwise, and can be helpful. And they're free, so go ahead and check those out and tell your friends to take a listen to them as well. This slide should be in your compendium or on the thing. So when I switch, because I have a better slide to show you, then we can go from there. So that's me and my bro when we were kids, and that's us a few months ago. And this says "a beautiful child," and I said to my mom, "That's so cool that you bought me a shirt that said a beautiful child, so I would know that I was special too." And she said, "No, that was a hand-me-down." So. All right, I'm ready for any questions that you guys might have. Yeah, please, right here.
Most of the were here in Indianapolis. Here's the help of the
No, so most of the programs, you're right. The question was, where are the adult centers? Most of the programs are primarily pediatric based, and I think that a lot of that comes from the fact that that's where the funding comes. The parents are involved and whatnot, and then as the kids become adults. And then you've got siblings that are kind of taking over from there, maybe in the caregiver role, or maybe they're living independently, the person with Down syndrome. The hard part is there's not that same mentality of, hey, let's get a center going. And so they are pretty rare. The idea of having an adult center is pretty rare. And most pediatric centers are not set up to see adults. And so it's a part, in fact, 100% of our adult center is independently funded because the adult hospitals don't really care to have an adult center because it's not really a money maker, quote unquote, for the hospital system. And so the money that we generate, or not we, but the Down Syndrome Parents Association generates, the vast majority of that goes to maintaining our adult center. And then the pediatric center again is more. It still has significant funding from the Parents Association, but nowhere near as much as the adult center does. So getting one of those started really requires a dedicated local parent group or association that's willing to share those funds to create a center, knowing that children eventually become adults, you know.
Is it for adults to have a Down syndrome clinic?
Yeah, I think it's important. I think that just like we were talking about where pediatricians don't see a lot of children with Down syndrome, adult physicians really don't see a lot of adults with Down syndrome with enough frequency to know what to look for. And I can tell you this diagnosis of early onset dementia, Dr. Bulova, who does the adult part of our center, tells me that that's one that, oh my gosh, it was sleep apnea, or it was hypothyroidism, or it was, celiac, or something so treatable that was just being forgotten and neglected and just saying, well, it's probably Alzheimer's. And I think that's a tragedy. So, yeah. The extra chromosome lends itself to larger red cells. It has absolutely no medical consequence that we're aware of, and it's something that will be flagged every time the blood count is done. The MCV, which is the size of the red cell, always is high in the kids, and it's not folate deficiency, which comes along with alcoholism, and it's not B12 deficiency. It's just Down syndrome. They just tend to have larger red cells. Yes. Yeah, in the back. Yeah.
I have a almost 4-year-old.
Yeah, so the question is about Miralax, which is like water, you know what I mean? It should be in the water system in America, where all the constipation that goes on. But no, the question is it safe to use? And there are definitely a lot of internet sites that have popped up talking about, is it antifreeze and all that. It's not antifreeze, first of all. It sounds like ethylene glycol, but it's not, okay? It's actually a different compound altogether. And the problem is in pediatrics in general, we don't really have studies on the medicines that we use. We extrapolated from adult data. And so we say, well, it's good for adults, it seems safe for adults, so let's use it in kids too. So when this whole thing came out that Miralax isn't tested in children, I just kind of said, well, nothing, And unfortunately, we're just now getting to that point where drug companies are being asked to make sure that the drugs are safe in children, because children are not just little adults. When it comes to Miralax in particular, the one thing about that medicine that is probably more reassuring to me is that what goes in all comes out. Because Miralax works because it's not absorbed by the body, and so it brings water into the colon and out comes softer stool. So it's not going to get to the brain and the heart and the lungs and all that kind of stuff. So it's if you were looking at a medicine that you were going to have your child on long term, Miralax wouldn't be the first one I would be worried about. Yeah.
Are there any other medications?
As they get to adults. So there are no specific adult healthcare guidelines. They're being worked on, but there's no specific adult healthcare guidelines. So most people extrapolate from the pediatric to go to adults. So the annual thyroid screening, considering celiac screening, hearing screenings, all the things that we talked about, we just apply to the adults as well. But those things should be followed that way. And the pediatric healthcare guidelines are available in parent understandable forms. I think, Marilyn, it's on healthychildren, right, .org? Yeah, healthychildren.org. You can find a parent version of the healthcare guidelines. And then in the pediatrics.org, which is going to be where the medical piece is, but you can share that with your doctors as well, is available at pediatrics.org. Just search under Down syndrome. AAP.org? Oh, okay, yeah, AAP.org, sorry. Yes?
Teeth grinding, is that, my grandson is 4.
Yeah.
And I thought he had something in his mouth, and I couldn't get it open.
Yeah.
But it's normal?
It's a self-stimulatory behavior that a lot of children and adults with Down syndrome do. Dental care is important to watch for that. Some of the dentists will sometimes try to, cap those teeth in the back so that there's not enamel loss and those types of things. But unfortunately, it's hard to completely resolve because it tends to be a self-soothing kind of thing that a lot of children with Down syndrome, both with and without autism, will do. So, 1 second. Yeah, you've been waiting. Yes.
How do you treat, or is there a cure for my grandson gets a bump here, and sometimes it goes down.
Uh-huh.
When it goes up, it's
Yeah. Hard to say exactly without seeing it. The question was what some of the kids might get a bump in between their muscles in their belly. If it's what I think it is, it's a very common condition where a little bit of the bowel kind of comes out this way and then goes back in, called diastasis recti, big long word. But essentially, it's your two abdominal muscles have a little bit of a lower tone, and what comes out in between when they flex their muscles, it's nothing to worry about. It's not a true hernia that needs repair or anything like that. Okay. Yes, in the back. No. So the question was, if you have an abnormal cervical spine x-ray at one age, does it stay abnormal then for the rest of the life? And the answer is no. And that's part of the problem with the x-ray, is that it sometimes picks things up, sometimes doesn't. It's a dynamic thing, too. It depends on, how far is their neck flexed when they get the x-ray or extended when they get the x-ray. So that we see very commonly where one time it's read as too big, and then they repeat it a year or two later, and it's normal. And so, again, this is part of why we try not. Yeah. The hard part is once you make the diagnosis, it's very hard then to, as a parent or a care provider, to just ignore it from there on out. If there are symptoms, he needs to be evaluated, the symptoms we talked about before, with something more than an x-ray. If he doesn't have symptoms, I would just refer you back to have you seen a neurosurgeon or an orthopedic surgeon about that? Yeah. 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 No, it comes in, it very, very frequently disappears, and which is why, again, the x-ray, we're irradiating all these necks all the time, or we were, and trying to back off on that, I think, is... Oh, yeah. Oh, yeah, it's hard. The kids don't like being x-rayed many times. Yes? Yeah. The question is, if luck has been good on your side, a child has been blessed up to this point with very minimal medical issues, can that be a sign then that the medical issues won't come in the future? There's no way to predict anything like that. But the big ones that we have, emergency surgery type level stuff, intestinal obstructions and heart related issues, those tend to be good. If they're good up to 4 years of age, you're gonna be in good shape on those levels. But it doesn't say, forever things are going to be good. I mean, if your child doesn't have Down syndrome, there's no way to say, that bad things aren't going to happen down the road. Yeah. 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 The lack of guidelines in the adult population should not be interpreted as lack of healthcare problems. It's just a sad lack of guidelines, and that's something that my adult colleagues are very, very interested in fixing. Yes? Yeah. Yeah. So, Marilyn, where can they go to find adult clinic listings? Do you know? Yeah. Pittsburgh has one, and yes. They're very, very few and far between. There might be 15 adult centers maybe in the country. There are, I believe either the NDSS or NDSC has a listing of clinics that you can find. And maybe, yeah. Yes.
I was very good about having a 7-month pediatrician and having a thyroid check.
Yeah.
Maybe the doctor, pediatrician, is going to cover the diagnostic clinic.
Yeah. Yeah.
And so I've been a very bad mother in the last couple of years when I got prescription. Because I didn't have to do a blood draw. Is there any other way?
To check thyroid. There's no other way besides a blood draw, unfortunately. Unfortunately, Yeah, that's a very difficult thing for the kids, that annual blood screening. A lot of times visual distraction can be helpful if you bring the iPad with the favorite movie going, that kind of stuff.
I'm probably better off on one of our visits to our children's hospital. Mm-hmm. Ask them to do it there.
Mm-hmm.
Versus to start
I would agree. Yeah.
all of it.
Yeah. Yeah. You've been waiting, yes?
Yeah, my daughter has all these back problem in my ear.
Uh-huh.
We have done the cleaning done.
Yeah.
She was either Spanish or in the anesthesia.
Yeah.
Still skip.
Yeah.
Really, every all the time.
Yeah,
It's hard to even treat with this, wax.
Yeah, the problem is wax production, earwax production. The kids with Down syndrome are like the heaviest wax producers in the world. Mineral oil or Debrox, Cerumenex, those kinds of over-the-counter things, hydrogen peroxide drops, those can be trialed, but may not be tolerated well. And I remember very not fondly, my brother, we would have to go into ENT and get the ears cleaned out on a regular basis. And while we were there, they would say, "Hey, do him too." And I'd say, "No," because they got to suck all that stuff out. Oh, anyway, there's no easy answer for that one. The over-the-counter drops. Yeah. 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 That's the trouble. Yes. Yes. Kidney issues. Yeah. So that's just in general in pediatrics. The question was ear skin tags and their association with kidney problems. Kidney problems on their own are not more common in people with Down syndrome as far as we know. But whenever in pediatrics we see anything with the ear, we very commonly try to check the kidneys with an ultrasound as well, was all I was trying to say. But it doesn't mean that they're going to have kidney issues. And Down syndrome is usually not associated with kidney problems. Yeah. Yes.
Would you recommend getting the tubes in the ear preemptively? I have a 4.5-year-old and he has not needed tubes at 5 months.
Yeah.
And he took them all still on him, and it was fine. And I had no problem with it with my daughter. I'm like, we met our deductible this year. Let's hurry up and do it while it's free.
The question is whether ear tubes should be done prophylactically in kids who do not have any ear issues who have Down syndrome, and I don't think that's necessary. If they Anytime you put your child through anesthesia, you're putting them at some risk. And so if they're not having hearing loss, if they're not having recurrent ear infections, I wouldn't recommend the ear tubes. Yeah. In the back you had a question. I'll get to you too. Actually, since it's past time, if you do need to go, I will not be hurt if you need to go. If you have questions, I'm here. Oh, yes, and please leave your evaluations. Bad evaluations keep with you. Yes. Yes.
My question is, should I be worried, because it's only not worried, and there's a high risk of autism, 4% in 4 sides of the family.
Yeah.
And the neurologist told me don't worry about it.
Yeah.
When she starts going like this,
Yeah.
I worry about it.
Yeah. So the question is about tremors in children with Down syndrome, essential tremors and things like that. Not something that I see very frequently, so I don't know that specifically what it might be with her. But the Alzheimer thing is definitely something to keep an eye on. Both sides of the family have higher risk of Alzheimer's, and then you have a child with Down syndrome. Definitely want to keep track of those types of symptoms.
But is there, I'm wondering if that is an sign of Alzheimer's?
No, I don't think that's an early sign of Alzheimer's. No. Yeah. Yes. Yeah. So the question, the question is about thyroid. Yeah. 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 The question is, with thyroid testing, is there a different normal range for people with Down syndrome? Should we be treating more quickly in children with Down syndrome if they are even in the quote-unquote normal range? That's a great question. It's one that we talk about a lot. As a consensus, as a medical group, we use the regular ranges, and we treat only if the children develop abnormalities outside of the normal range for age. for thyroid. So there are folks who have talked about supplementing thyroid more liberally in people with Down syndrome. It's just not known to be effective. Yeah. Again, we don't recommend thyroid supplementation in the absence of lab findings of hypothyroidism. Yeah. Yeah. Yes. Yeah. Yeah. Uh-huh. I would refer to Maryland as St. Vincent versus Riley. They both have programs. It's just a terminology choice, I think. Yeah. Mm-hmm. I see. Yeah. I'm not familiar enough with that program to know exactly whether they have one doctor that focuses on Down syndrome or. Yeah. Uh-huh. Yeah. Okay. I don't know them personally. Dr. Bull might be able to help with some of that afterwards, but I'm not, because she works at Riley, but I'm not sure the specifics of the program there. Yeah. Yes, in the back. Yes. Most commonly, the thought by ENT doctors is that the tongue size, when it's measured, is just like everybody else. The mouth size is a little bit on the smaller side. So hence, many of the children or even adults will have their tongue hang out. And many times their tongue is hanging out because it's obstructing in the back of their throat. So it's actually easier to breathe with the tongue out. And that could be a sign of sleep apnea, too. Yeah. Yeah. It can. It also can be because of the lower tone in the mouth muscles as well. Yes. Yeah. 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 7 months old, I wouldn't worry about that at this point. Yeah. 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 Yes.
In the early years, exists some checkup study for preventing the medical issues for the kids.
One more time.
A checkup
A checkup.
for the kids
Uh-huh.
to prevent all the issues. I know I'm from Mexico.
Yeah. Are you close to Mexico City?
Yes.
There's a center there.
Yes, but I want to know medical if I bring my kid and has a checkup for all the
Yeah.
prevent all the
Uh-huh.
issues that
Yeah.
medical has exists.
That I think the clinicians from the program in Mexico City come to the meeting every year. They seem to have a large group of people very interested. So I think that would be a good idea. Yeah. Any other questions? Yes. So the goal age is by the age of 4 for them to have a sleep study. If they haven't had it by age 4, especially if there's signs of sleep apnea, you should get it. Even if not, the thought is that a sleep study should be done for all people with Down syndrome, preferably by the age of 4. How old you said? 5 months. Uh-huh. Yeah. 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 Well, reflux is certainly very common in children with Down syndrome. If it's a small amount that's coming out, if it's huge volumes of vomiting, that's a real concern. But if it's just little bits that are coming out and it's seeming to impact his feeding, then talking with your doctor about reflux management would be a good idea. We certainly would recommend that. Yeah. 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 Yes. Oh, my. I forgot one half of the room. Yes. Yeah. Yeah. Sure. So the question was, how do you diagnose celiac disease? So there is a genetic component to celiac disease. We know that certain people, certain types of genetics put you at a higher risk of celiac disease. And the first step is then to screen with blood testing. And the blood testing is two tests. One is called an IgA, and the other is called a TTG. And your doctor will send those two tests off, and then based on those results, will decide whether or not seeing a GI doctor would be indicated. The lymphoma issue I was illustrating is more the children with Down syndrome, if they're asymptomatic, don't seem to develop any of these long-term complications. But with the family history, it might not be a bad idea to talk to your doctor. We try to wait until the kids are about 2 before we start sending celiac screenings. That gives them a good amount of time where they've been exposed to gluten and wheat products and things like that, so that if they were having intolerance problems, we can catch it. Yeah.
He was also born with CMD.
Uh-huh.
And we banked towards blood at the time.
Yeah.
Our doctor at Vanderbilt at the time told us, well, it's not going to be, it can't be used.
Yeah.
So we donated it for research.
Uh-huh.
Do you agree with that? Or
So the question is one of blood banking for potential future use in the patient themselves if they were to develop leukemia or something like that. Almost every pediatric oncologist will not use cord blood from a baby who later develops leukemia because you don't know if that's already present. The leukemic stuff is already present in the cord blood. So very often they won't use it. Yeah.
And then what about if we had some children and banked their blood?
Mm-hmm.
Can that be used for him if we develop leukemia?
If it's the same type of, if they have a good match, all that type of stuff, they would.
The issue of Down syndrome does not matter.
Yeah. Yep. Yes.
You know how you showed the genetics test I think you showed for mosaic.
Yeah.
People always ask, is my daughter's mosaic?
Uh huh.
And I say, no,
Yeah.
no one ever said that. But
Yeah.
it did show specifically on the genetics test.
So the question is, how do you diagnose mosaic type Down syndrome on the screening? So very commonly, what happens is the blood test comes back and it says something like 25 out of the 40 cells had trisomy 21 and 15 did not. And so that lets you know that some of the cells had trisomy 21, some did not. But of course, that's only specific to the blood cells that were sent. If they're mosaic, meaning their liver is the only organ that has trisomy 21, you won't know because no one's going to biopsy, every organ in the body. But most commonly, the blood cells are checked, and if there is still concern or desire to know if there's mosaic type, you can actually do a buccal test, meaning the doctor will take a smear of the cells in the mouth, in the inside of the cheek, and send that off for thousands of cells for sampling, and then they can say, 999 out of 1,000, had Down syndrome, had trisomy 21, that kind of thing. I don't think it's all that important. Yeah. I don't think the percentage means anything. We have some kids who are very low-level mosaic type, who have very low-level mosaic type Down syndrome, but developmentally they're not doing really well. And then we have kids who have standard trisomy 21, and developmentally they're doing great. It just really depends on which cells and where are affected, not really the percentage so much. Yeah? Yeah. So the ENT, the question is, what can ENT do about the narrow airways and things like that? They will do tonsil adenoid type stuff. If the children have sleep apnea, removal of the tonsil and adenoids, which all live up in this area, opens up that space a little bit. There's been some discussion, too, about, from the dental world, if we expand the palate so that high arch kind of straightens out, does that open up more space in this area? And the length, the obstruction of the tongue in the back of the throat. Sometimes the ENTs will kind of clean that, make that smaller so that there's less obstruction in the back of the throat. So there's all kinds of surgical things that the ENT doctors will do. But typically that requires some sort of diagnosis, be it sleep apnea or recurrent sinus infections or something like that. Different orthodontic dental folks are trying that if there's high arch to the palate. It's not the most comfortable thing. When I was a kid, we didn't have those expanders. But all my kids, when they get their braces now, they got to get these expanders in there, and they're no fun. I can't imagine how great that would be for somebody with Down syndrome who already has, maybe some speech issues, maybe some feeding issues. To have that thing in their mouth might be pretty difficult. So, yeah. Yes. Yeah. Yeah. Uh-huh. Yeah, so that's the hair loss thing, that's called alopecia areata. It's pretty common in Down syndrome. It's an autoimmune condition like we were talking about. It's one of those things that just happens. Their body, for whatever reason, fights their hair follicles in that situation. Some dermatologists will use like a steroid cream over the area to help calm down that inflammation. Very often, it's hard to tell whether it works or doesn't work because that's a come and go type condition. You might notice that in 3 months, her hair's all back, and you didn't do anything. And then you might notice a year later, more hair gets lost. And it kind of does this come and go type of thing. The one thing we hope for is that it just remains small patches because sometimes in the kids it can become very extensive, eyebrows, all this stuff. And so we like to hopefully avoid that. If it gets that severe, we try everything. Dermatology will recommend. But if it's just a little patch, some families will just wait because it does often self-resolve. Yes?
So if you have an adult
Yeah.
And we come out to Pittsburgh,
Yeah.
do you run through all the tests, blood tests, the whole
Yeah.
bit?
The one thing that we'll obtain is all of the medical records that have been done. And then yes, and then they go through, Dr. Bulova, or if it's a child, I do, go through every thing that can be affected and what needs to be done and testing that needs to be done, all that stuff. Yeah, yeah. Yeah, so for me, it's, for pediatrics, it's a little bit easier for us. It's still about a month or two before there'll be an open slot. But for him, it's even harder because it's just him and he does it part-time. So probably you're looking at 4 or 5 months out to schedule an appointment that way. Yeah. Yes. Higher than the typical population, without a doubt. So about 40% of 60-year-olds with Down syndrome will have Alzheimer's. But it's certainly not as high as they once thought, when they thought everybody with Down syndrome had Alzheimer's. It's lower than that, but certainly still higher than the general population. Yeah. I think that would be something to if you have family members with Alzheimer's, no matter what. Yeah. But as now with having, with kids having Down syndrome too, you would want to keep that in mind. Now, there's nothing to do for it right now. They have done some medication trials. That medicines that are effective in adults who don't have Down syndrome with Alzheimer's are not effective in adults with Down syndrome. And we don't know why, but that was a big trial. They were hoping to find something, and there's nothing. So, for now, I think that's an active area that people are looking into. Yeah. For thyroid. Yeah, thyroid is like, if there's one diagnosis that somebody with Down syndrome gets that's a lifelong one, thyroid is the one to get. I mean, it's the most easiest treated condition. It's a once-a-day medication. It's just replacing the hormone your body's not making. And it's not injected, it's just a pill, and you just take it once a day, and it corrects. Say again? Whenever they develop signs of low thyroid, it could be day of life 1, or it could be when they're 65, 80. Yeah. Because you're only replacing what the body should be making but isn't. Yeah. Yeah.
But in the absence of normal
So hoarseness in a child with Down syndrome, the first thing I would think about would be reflux. Are they having reflux that's going back and irritating the vocal cords? And in the absence of, well, actually, if I have...
Like a 15-year-old who had reflux when she was a kid.
Still might. Yeah, oh yeah, reflux happens all throughout the lifespan. And often, when they're babies, they and out it comes. But in adults or older children, they may not. So the pain, I don't talk about this in the slides, but pain reception in people with Down syndrome is definitely altered. Most of the time, like the woman who was saying about the fear of the lab draw, it's not the pain of the lab draw. Very likely it's the fear of the situation, but not the pain of the lab draw. Pain sensation is definitely altered to being, they're less pain sensitive. So they may have horrible reflux and have no pain. Yeah, so if there's chronic hoarseness, that's the first thing I would try. Would be a trial, a couple of weeks of Zantac or something like that. Yeah, just try it. Try it for a couple of weeks. No. And then if that doesn't help, then I would have an ENT see her. Yeah. 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 Yeah.
Well, you mentioned something about he's not low the perception of pain, though, but
Yeah.
that's altered. Can they have over-perception? I've got a brother who's got some chronic, he can't figure this out, but neurological pain.
Yeah.
Like, feels like hot burning shingles.
This is in a child with Down syndrome. Somebody. Oh, with Down syndrome. Oh, uh-huh.
And we can't figure it out. We've been all over. They think it's occipital neuralgia.
Oh.
Really, really hot.
Yeah.
Child to have.
Yeah.
But do they sometimes have altered perceptions of pain?
Severity pain? Not usually. It's usually the opposite thing. Like, had a broken leg for 2 days and we didn't even know kind of attitude. Many of the time. So that's why distraction is a great technique to use, because if they're distracted watching some thing on the iPad or something like that, the needle goes in, goes out, nobody even knew. So that's a technique we use a lot when we're doing lab draws. So, all right, yeah, please. Yeah. 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 When we think of bacterial sinusitis, we think of it as symptoms for at least 10 days. Yeah, if there's a runny nose for at least 10 days, certainly if it's changing colors, becoming more thick, high fevers, headaches, all that kind of stuff, then we start thinking about bacterial sinusitis. Otherwise, if it's just a viral thing, we try to let it ride as long as possible. Yeah, daycares kind of run the show a lot of the time in schools. They want us to treat every viral infection with antibiotic, but it really doesn't make a difference in terms of infectious risk because it's a virus. Yeah. Yes?
2 questions.
Okay.
What was your presentation on DVD?
I don't think it's on DVD. Yeah.
You come, we're in Rochester, New York.
Yeah.
Come to Down syndrome thing, do a presentation there.
Come to where now?
Rochester, New York.
No, to do what now?
Your presentation.
Oh, yeah, if somebody invites me. Oh, got it. Yeah. Well, yeah, I mean, we like with the Rochester Health System up there or something. Yeah, just have them. Oh, the network. Oh, yeah. You can contact us. Just send us an email at that email address that I had up there before. I'll put it up there again. DownSyndromeCenter@gmail.com. Yeah. Yeah, just send us an email. Yeah, sure. They have studied using nasal steroids in people with Down syndrome and obstructive sleep apnea, and they have found it to be helpful in a certain percentage of those kids. And so if I have a family that's already done the tonsillar adenoids or anxious about doing something like that and their kids have recurrent sinus infection, we found some benefit in using the Flonase or Nasonex or whatever it is that they have. Yesterday we were asking the ENT that very question at our medical conference. And she said what she uses very frequently right at the onset of symptoms is just some nasal saline, but not based on what the bottle says. It's saline, it's safe, it's just salt water. She goes like 6 or 7 squirts on each side. Just wash that junk out, usually down, because they won't blow it out, but many times. But yeah, just squirting a bunch of nasal saline up there to irrigate that area tends to be helpful, she felt. Yeah. Yeah, that's enough to just moisten it, but you want to just wash it out. And then adults, if you go to an adult ENT, they'll put a tube up there and they'll dump the saline down. You know what I mean? But of course you can't do that with a kid. But doing the spray, just doing a lot of it might be something to think about too. Yeah, you just have to be very consistent with the nasal steroid if you want to see if it works or not. It's got to be a daily thing. Especially when the season hits, August, September. You have to use it every single day. It doesn't work as needed. Yeah, that's a big dose. Yeah, that's usually I do one spray once daily, but that's fine. Yeah. Yo, please, take this. Yeah. I'm sorry. I was going to walk out.